And a lot of it centered on patients who either are not seen here or are seen here, but come from long distances, if they'll be able to participate in the patient-centered specialty home.
So if you're not a patient here, I'm not sure how that would work because, in fact, you could do it, but you would have to come in every 6 months, so that because part of the specialty home is we want to examine you and see how your walking is and do things. So if you're not a patient here, we could still do it, and please leave your name and we can work something out. For those who are patients, this will fit into your regular visits. You really don't have to be seen, but every 6 months, in some cases every year. So whether you come in every 6 months or even more frequently, doesn't matter. A lot of the surveys you'll do at home on your own time. They won't take very much time. A lot of the data gathering we will do, the patient portal, you can use it anytime. So really the only time that you need to come here is really part of your regular office visit. What we'll do is when you come and you see any of us, and then if you're part of the trial, then you can just say, oh, Nasima or Lexi, and we'll have some other people that'll be helping us. Once the visit's done, they'll just take you to a different room and say, okay, why don't we just do a couple surveys together, and then you won't be there that much longer, and then you'll be out the door. A lot of the data gathering is done outside of the clinic, and that's the idea. We want the study to be patient-centered also. We don't want it so that it's cumbersome. We want to make it as easy as possible. So if you're not part of our group and you want to be part of the study, leave your name and we'll figure it out.
Sorry, Dr. T, it's going to be sort of a two-part question. And then also, so will the patient-centered medical home initiative include coordinated efforts to include other specialties such as physical therapy, your primary care? And patients are also asking how their family can be involved as well.
Absolutely. So this is the whole idea, is that care with physical therapy, other specialists, with your primary care doctor is all going to be coordinated. Either we do it, or you might say, you know, I like my primary care doctor, I'm just going to stick with, that's fine. And so we will have their contact information so that we can communicate directly to them and let them know what we're doing. Family members are a critical part of a home. I come from an Italian family, as I said, and so my mom told me, you know, without mom, ain't nobody going to live around here. So we have a strong sense of family, and you know how the caregivers are part of this process is critically important. I think we are even going to introduce a caregiver survey, which we think will be extremely important. But we didn't want to start that because that requires the caregiver to actually give their consent to being part of the trial. So we want to start easy, and then we will expand things. I mean, ultimately, we would like to have several internists in our department so that when you come for your visit, you could also see an internist. We'd also like to have a urologist there. So when you come, if you wanted, you could see the urologist at the same time, make it all one-stop shopping, if you will, so you don't have to come 6 different visits to, you know, 5 different facilities. You could just come one time at that 6-month time point, see a lot of people. It's a longer visit, but get it all taken care of. It's an idea that's, again, a couple of years away, but that's ultimately our goal, is to just have it all in one spot.
Okay. I have a question for Dr. Osborne, and it's a two-parter also. Okay. To be tested for optic neuritis, should the patient see an ophthalmologist or an optometrist?
So I would recommend seeing an ophthalmologist. You can go to an optometrist if you want to get your glasses checked or if you're getting your contact lenses replaced. But for neurologic complications of MS, it's best to see an ophthalmologist.
Okay. And the second part is a question about, are there any, we had several questions about any exercises that can be done to strengthen the eyes.
So that's an interesting question. There's a lot of controversy in the world of like eye exercises and how beneficial they are. The problem with it is that there are eye doctors out there who you can pay them and they can teach you eye exercises, but a lot of times insurance won't cover it, and so you have to pay out of pocket. So if you want to do eye exercises that are available for free online on the computer, where you're shifting your eyes back and forth or focusing at different fields of death, and with virtual reality, if you get virtual reality goggles, you might be able to even do more types of eye exercises potentially. That's fine, but I'm always hesitant about recommending actually paying some specialists to get eye exercises where it's not clearly beneficial, the benefit that you can get, and a lot of times you do have to pay out of pocket, unfortunately, because insurance won't cover it. So if you have the money and the time to do it, there's probably no harm, so you can certainly look into it.
Thank you.
I have a question for Dr. Shen. So a common theme among the questions was, how do you know if you're on the right drug? How do you know if it's working? How do you know if your progression is being slowed? And then the second part would be, what sort of things do you look at if you're going to change therapy? Do you need to look at the MRI?
Okay. That's actually a great question, but a challenging one. So for many years in the MS field, people have been trying to figure out, how do we define treatment failure? Let's say you're doing an MS medication. How do we know if it's working? And I would say as a field, we've sort of struggled with this question. There really isn't consensus. But what I would say has changed over the years is I would say we're much less tolerant of MS disease activity over time, meaning there was a time not that long ago where if a patient came to see me and I said, oh, how are you doing? Oh, not bad. Have you had any attacks? Well, I had an attack last year, maybe 2. I used to think, well, that's not bad. Or maybe we would look at an MRI scan and I would compare them. I'd say, well, this is pretty good. I only see maybe 2 or 3 new spots. It doesn't look very active. And we used to be tolerant of that, and we'd say, well, if you're tolerating the medicine, why don't you keep going? I'll see you in 6 months or a year. Recently, I think there has been a shift, possibly because we have so many more treatment options now, and I think the effectiveness of the medicines is getting better. So I would say we're less tolerant of activity. My goal, at least personally, and I don't know, I can't speak for the entire group, but my goal when I see a patient is for that patient to not have any more MS attacks. My goal would be for there to not be any change on MRI over time, or maybe it could improve a little bit. And my goal really would be for there to be no worsening of disability over time, meaning no extra limitations. Now, it's kind of aspirational. I can't always achieve that. But, I use the analogy, or really we stole this idea from oncologists. If you were, heaven forbid, diagnosed with cancer, the goal is usually to become cancer-free. The goal of treatment is to become cancer-free if we can achieve that. We can't always do it, but that's what we aim for. And I think in MS, we're starting to be like that. The goal is no activity, no attacks, no change, no disability. Now, the question that you asked is, but how would we know if we're achieving that? We can't always do that. It's why we have regular follow-up visits so that we can assess how you're doing. You would obviously tell us about different symptoms you're having, and we do recommend regular MRI. And I will also say another thing that I've changed is that I do MRIs more frequently, honestly, than I used to. So I would say at least once a year. I think I should at least look at the MRI to see if things are quiet. We often in talks say that MS patients can have up to 10 spots show up on the MRI for every actual symptom they experience, which means that there could be a level of activity that you wouldn't even feel that maybe we could detect if we do MRI. So that's really personal in the sense of there is no correct answer to the question you asked, but that's at least, I would say, my approach to treating MS.
Okay. This question is for Susan Stewart, the NP. Recommendations for vitamin D, B12, B7, magnesium, melatonin. And do we monitor the levels of B12 and vitamin D?
Hi, that's a good question. And yes, we do. So vitamin D, we want you to have a level of 60 to 80 is what we strive for. That's higher than what your primary care provider would recommend. But in MS, it's important, and that's what we strive for, whether that's taking 5,000 a day or 50,000 a week. And we do measure that. That's part of our routine labs. The B vitamins, B12, again, we measure that. We encourage you to take supplements as well. We may start you off with 2,500 micrograms and then may lower it depending on your dose. That can also be in your multivitamins. B12 is typically found in meat and beans and tofu, some other dietary sources, but again, we don't want you deficient in B12 as well. And biotin, which is actually B7, we don't measure that, but we encourage you to take biotin as well, and that's typically 5,000 micrograms a day. Did I answer all that?
Yes, thank you.
Thank you.
Dr. Mora, could you describe for us what sort of patient you would refer to the stem cell transplant? What would they look like necessarily? What symptoms would they have? A lot of patients were curious about that. What would, or not you, maybe refer to it, but
I will say,
what sort of patient would that look like?
with the current therapies available, probably it is more and more difficult to actually get to a point of making that decision, of saying, actually, Madam, sir, I believe you are definitively a candidate for referral to a bone marrow transplant center, because more and more therapies are coming, dealing with, especially with the B cells. As we said, actually, ocrelizumab is about to be approved by the FDA, hopefully, before the end of the year. So it's tough, actually. One thing is to review all these papers, make these slides, present, and another is to be in front of somebody and say, I believe definitively the bone marrow is going to be the final solution for your case. But at the same time, we have learned that we should not wait until the patient is significantly disabled. And sadly, many patients who bring the topic to the clinic, we already realize they are in a significant stage of progression of disease and disability. I would say, basically, if a patient is, again, in the, let's say, third, fourth decade of life, very aggressive presentation, 4 or 5 admissions to the hospital, MRIs, 15 enhancing lesions, and then after 3 months, those 15, 9 of them are okay, but then we have 6 new more, and the patient already reached pretty much at least one of the monoclonal antibodies, I will start thinking on referral to bone marrow. Of note, key question, why in the Eastern Coast there is not a dedicated center for bone marrow transplant? Actually, this week we spoke with Dr. Scott Rowley here, director of the bone marrow. We have the technology here. One issue will be insurance. But again, I think it's going to be a difficult process of thinking to make that decision, because we're getting more and more actually good therapies that at some point may question the validity. At the consortium of the MS Centers meeting last May, several of us were there at that session, the bone marrow transplant, and I addressed the question to Dr. Paolo Muraro, one of the European leaders in the topic. And I addressed the question, is alemtuzumab, Lemtrada, going to replace the bone marrow transplant? Pretty much the consensus of all those authors and investigators was they actually started moving their head. No, it's not going to replace the bone marrow transplant. Yet we have to say, let's watch. This doesn't mean that I'm voting for Lemtrada as the main therapy. What I'm saying is, as new therapies come, probably we'll be referring less patients for the bone marrow transplant. But still, the bone marrow transplant may be the last alternative for a patient with very fast progression.
Okay. This question is for Dr. Amjad. How often can baclofen injections be given, and is there a threshold for it to stop working?
So the intrathecal baclofen pump, I think that's what we're referring to here. So it depends on the dose that we program into the pump and the concentration of the drug itself, and along with the volume. So the baclofen pumps can hold 20 mils to 40 mils. That's usually the range. So we can refill the pumps as frequently as every 90 days, maybe even less. We don't want the pumps to go without a refill for more than 5 months or so, because even if you don't run out of the drug, there's a chance that the drug's potency, the effect of the drug, how powerful it is, will begin to wane. And once that begins to happen, there's always a chance that people's spasticity may get worse. What we don't want to ever see is someone to go into baclofen withdrawal, because that can be dangerous. But typically, most pumps are refilled about 90 to how many months, Dr. T?
5 months.
5 months, yeah. So that's typically how long you can go without a refill. And then again, but you can come in for the adjustments every week if needed, especially when it is first implanted.
Second part, Dr. Amjad, was someone had a question about, does the baclofen refill require surgery, or is the medicine just injected through the skin into the device?
Yeah, I should have gotten more into this during the actual talk, but the surgery comes in when the pump is first implanted. A neurosurgeon has to do this, and we have one here, Dr. Calhoun, who's excellent at putting them in. But once the pump is implanted, you would come to our office. You would come see me or maybe one of the nurse practitioners. to actually have the pumps adjusted and to have them refilled. The refilling part, it just requires a needle. We put the needle in through the abdomen. We can access the pump that way. We can take out the old baclofen and put in new baclofen. So it's pretty straightforward. The pumps do have to be replaced. The Medtronic ones at least do every 5 years or so because the battery may stop working. So that's a much more straightforward surgical procedure compared to the initial implantation of the pump. Hope that answers your question.
Thank you. So this one, actually, any of the panelists could jump in, but I think one part may be for you, Dr. Amjad, specifically about CBD oil for spasticity as an anti-inflammatory, and then also just in general, the use of marijuana for patients with multiple sclerosis and their symptoms.
Yeah, so there is a lot of research going into spasticity and pain and how marijuana can help this. The problem with marijuana is that, there's no set dose yet. It's not like one dose has been studied or one kind of, because there are different types of marijuana out there. And then there's a CBD oil. There's also something called Sativex, which is an oral spray that's available in Europe. And yes, for the most part, marijuana can help with spasticity and pain. The issue with marijuana is that it can have cognitive side effects. It can worsen someone's cognition. If you've ever been high, you would know that. It can also worsen someone's balance. And then also the duration of effect is not very long. Personally, I think marijuana it is something that can be used. I would prefer that we try the more traditional therapies first before we get there. And again, it's not really legal in most states. It is legal in Washington, D.C. Medicinal marijuana is. And I believe after the election, a few more states have legalized it.
Can I jump in?
Yeah.
So I have probably about 40 patients that are using medicinal marijuana in the district, predominantly for spasticity, some for neuropathic pain. And just a few things that we've learned. So there's really two ingredients in marijuana. There's CBD and THC. CBD is thought to be more for pain. THC is thought to be the more psychoactive part that makes you high. What we've learned is that you can't just use CBD only. That won't work. And if you look at Sativex, the drug that's approved in Europe for spasticity, which is basically derivatives of the marijuana plant, they use both. So it has to be a combination of CBD and THC. So what I tell patients are when you go to the dispensary, don't get CBD oil. I mean, I don't like them to smoke or vaporize. I think there's just a lot of issues with tars in your lungs. But you can get an ointment, where it's basically an oil extract of the plant called a tincture. And I tell them, get the tincture of a plant, not a derivative. And you just take a single drop, put it under your tongue, and that may be good for a good 5 or 6 hours, which is about the same as baclofen or tizanidine anyway, so you're right at the same spot. And one of my favorite stories is I had a patient, she was about 75, 76, lived in a district, and I said, you should really try this. She just hadn't done well with the oral medication. She goes, oh, Dr. T, I can't do that. I have grandchildren. I said, we're not going to smoke it in front of them. I said, you're just going to have a little vial that you're going to keep in your room. So she came back about 3 or 4 months later. We got her signed up, and I said, go to the wellness center up in Tacoma Park. They're terrific. So she goes, and she comes back, and I said, so how are you doing? She goes, oh, the tincture is very nice. If I put a little drop under my tongue, my pain is a lot better, my spasms a lot better. If I put 2 drops, I don't care. I said, okay. I said, and which one did you get? She goes, oh, I really like the Master Kush. She goes, I tried the OG Kush, but it's just not as good. And that is a true story.
Okay. Anybody else? Susan Stewart, I think you covered a lot of this, but about the adverse effects of sitting for non-mobile patients. Do you have any recommendations for those patients that are not able to be as mobile to get the exercise and prevent?
Right, and
disability?
so again, a referral to physical therapy. There are ways that everyone can exercise in some capacity. And again, looking at the MS Society website, they have offerings and programs. You can find places that are local to you where any level of disability can exercise. So again, I urge you to visit their table, go to their website, and ask us for referrals for physical therapy, neurophysical therapists.
Thank you.
Dr. Shin, another common thread was, one, if you could just describe secondary progressive MS and how it differs from the other forms, and then the treatment options that we have, how is it treated as well?
Sure. So I mentioned that most of the treatments that I sort of discussed were approved for relapsing remitting MS. So patients who are having episodes of MS problems, relapses, attacks, exacerbations, whatever term we're talking about. But some patients who start out with MS attacks over time, they have less attacks, which could be good, but they begin to gradually worsen with time. So maybe more trouble walking, it just gradually worsens. So when there's gradual worsening without episodes necessarily, we refer to that as progressive MS. And this way of looking at it may actually change. We might be changing our labels for MS, but if a patient starts out, the first thing they have is relapsing remitting MS, the typical form of MS, and then later they develop progression. We call that secondary progressive MS. First you have the attacks, and then you begin to progress. There are some patients, maybe we say 10 to 15% of patients with MS, who actually don't know what I'm talking about when I talk about MS attacks. They've never had that. The first or only thing they experience is gradual worsening, progression of MS. And so if the first and only thing you've experienced from is progression, we call that primary progressive MS. So, these are our terms, primary and secondary progressive MS. How do we know if someone's in one of those forms is mostly, honestly, by history, by talking to the patient. If someone says that, well, I've been gradually getting worse over time, not so much stepwise, but just there's a slide. You can't really pinpoint a time when maybe there was more trouble walking, it's just been gradually worsening. We consider the possibility that the MS has transitioned into that form. MRI can be helpful. We think that in progressive forms of MS, the MRI is actually not very active. Like, we may not see the same degree of inflammation that we see in the relapsing remitting stage of MS. So the second part of the question, I think, was sort of treatment options, and I'll just be honest and say that of the 14 different FDA-approved drugs that I mentioned, none of them have been shown to be very effective in progressive forms of MS. In fact, many of them, most or all of them, when tested specifically, do not really benefit the progressive form of MS. Having said that, I kind of put in italics, and Dr. Mora also mentioned, there's a medication that we anticipate will be approved shortly called ocrelizumab. I don't exactly know, obviously, how the FDA will label this, but some of the data that they presented suggested that it does slow progression in patients with primary progressive MS. There are other agents in studies right now, that, including an oral agent that looks promising, that may also slow down progression in primary progressive MS. So we might, it's been, what did I say, like about 20 years of treatment, at least for relapsing remitting MS. We might just now be on the cusp of having useful medications for the progressive forms of MS. So, maybe stay tuned. Maybe the next time we do this, we'll have probably a talk to talk about this a little bit more. But that's not here yet, but we think maybe it's just around the corner.
Dr. Osborne, we had quite a few questions about this. Will LASIK eye surgery be an option for MS patients who have experienced optic neuritis?
So LASIK surgery can basically help if you're wearing glasses or contacts. If you get the LASIK surgery, you won't need those glasses or contacts anymore. However, if you've had vision loss due to your MS or optic neuritis, if the glasses whatever you can get with your current glasses, that's the best you'll get with LASIK. So if you, unfortunately, have had maybe recurrent episodes of optic neuritis and you have decreased vision in one of your or both of your eyes, LASIK surgery won't be able to do anything to increase or improve that vision, but it could help if you are sick of wearing your glasses and you don't want to wear the glasses anymore. You could talk to an eye surgeon about that. That being said, the surgeon might be hesitant to do elective surgery if you already have visual impairment, because while LASIK is generally an extremely safe surgery, there's always risk with any type of surgery. And 1 in a million times, sometimes don't things go as well as you'd expected with the LASIK. And if you already have decreased vision, they might want to not take that risk because it is an elective surgery. But it won't help improve vision loss that's already occurred from optic neuritis.
Thank you.
We had several questions about bowel and bladder function in MS, so I didn't know if any of the panelists wanted to take that. We didn't address that specifically today. We didn't have time for everything. But what are the latest treatments for bowel and bladder symptoms, incontinence?
So things that we can offer to you would include, besides exercise, pelvic floor exercise, referral to the urologist who may do a surgical procedure that they could speak certainly more to you about. But there's also Botox that we've had several patients that have had Botox to their bladder, and it's been very helpful to them.
I'll tell you, so we've just recently partnered with a group from the National Rehabilitation Hospital that's looking at bladder infections. And they have some really interesting ideas about the bladder. So we used to think that the urine is sterile, that there's no bacteria in it. It turns out that's not true, that we actually have good bacteria in everybody's urine that keeps you from the bad bacteria from getting in. And people who have recurrent infections, it turns out that good bacteria is losing a battle against the bad bacteria, and the bad bacteria just keep coming back and you keep getting infections. So they have this idea that they just got approved by the FDA where they're going to take the good bacteria, in this case called lactobacillus, the same thing that's in yogurt, and they're going to put it into the bladder of people who have MS to repopulate the bladder. With the idea that if they do that, maybe that will get rid of recurrent urinary tract infections. So, and this is a very common issue. I would encourage you as you guys come in for your visits, the guys from the NRH are going to be there for the next month or so. And if you wanted to be part of a study looking at the bladder, they would be very happy to help you out. This is one of their areas of interest. They take care of people with spinal cord injury who've lost complete control of their bladder. And so this is a big deal for them, and now they're looking at MS. So we may ask you, why don't you go talk to those guys, and they may do more with you. Bowel and bladder issues are common. It's not just in an MS, it's everybody. My dad is 85, and I called him the other day, and he does not have MS, but he's got other stuff. And I said, Dad, how are you doing? He said, I'm beautiful. I said, really? He goes, last night I only had to get up twice to pee. It was great. I'm like, this is your life. He's so happy that only twice. Okay. But it's a common issue with everybody. Don't think that you're alone if you have bladder issues. But there's many, many strategies to deal with them. And as Susan said, it's a team approach. Some of it is lifestyle changes. Some of it is dietary changes. Some of it's going to be medication, maybe. And then in some circumstances, it's Botox and more invasive procedures, but very doable, very doable.
Okay. Dr. Mora, what drives the decision of having an MRI with or without contrast? Patients are questioning, sometimes they have contrast, sometimes they don't, and it's confusing to them.
So that's an important question, and especially because there was recently controversy about that eventually contrast agents, gadolinium or some forms of gadolinium that eventually will deposit actually in the blood vessels of the brain, and if this eventually over the years or decades will be harmful. So the fact is this, is most of, if not all of the clinical trials for the medications given for MS, one of the most important tools to assess activity or progression of disease, especially activity, and is still the MRI. And basically, when the blood-brain barrier is open, then the gadolinium from the bloodstream leaks into the brain, and that's when it enhances. So whenever we say, well, the MRI says you have 4 new lesions, one of them is enhancing, means that one enhancing actually is the most active. Means the blood-brain barrier is open there, the bad lymphocytes were able to cross and produce the damage that we spoke about. So that's what it is still important for us. and especially in clinical trials, to look for activity with the use of contrast. Still, sometimes we just say, and typical example, let's assume the patient has significant diabetes, a diabetes that potentially is about to cause complications. It's well known that gadolinium or this contrast media actually may be harmful for the kidney of those patients. At the end, at that time, I will say, well, this patient is not in a clinical trial. More than knowing if he has an enhancing lesion, I basically want to know if there are new lesions, and that can be determined without contrast. So sometimes we order the MRI without contrast. And there is a trend among some of the, we call us MSologists, multiple sclerosis, especially MSologists. There is a trend, a good number of MSologists actually not ordering with contrast unless it is strictly necessary. But basically, we go for increased number of lesions, some enhancing lesions. In research, they also check the volume. Is there actually brain atrophy over the years?
Thank you.
So we're getting close, but we are going to take one more question. So Dr. Tornatore, one of the questions is, what about patients, treatment for patients who are 70 and up?
So the question is, should somebody who is older be on medication? So there's a couple ways to look at this. So we are actually starting a clinical trial now of patients who are 55 and over who have MS that have been stable for 5 years. And in that study, once you're enrolled, you'll either stay on your medication or you'll go off. And then it's a 3-year study where we'll follow people, we'll do MRIs, we'll see you every 6 months. And this is a large study being done throughout the country. It was funded by a group called PCORI, the Patient-Centered Outcome Research Institute, which is it's a non-governmental, it's a private group, if you will, but they're funded through the government to answer this question. So if you're over 55, do you still need to be on medication if you've been stable? And you say, well, why wouldn't you stay on medication? Did the MS go away? What happens is, as you get older, your white blood cells get older and your immune system gets older. It's what we call immunosenescence, and they get less strong. And so we think that over time, the MS may burn itself out. And then once it does, you don't need to be on medication. But we don't know that for sure. And that's what we're going to try to find out in this study. My gut feeling is that we're going to find out that there are certainly people who do not need to be on medication over the age of 55, but I know for a fact that there are people who will need to be on it, because we've had this experience where people who are in their 50s, 60s, and even 70s will have an attack, we'll get a scan, and we can see active areas on their MRI. We're like, they didn't read the book. You know, their immune system is supposed to be quiet, and it isn't. So we're going to do the study, and we'll try to sort it out. And so we don't have an answer right now as to when the right time to stop the medication is. Some people will do it. They'll say, oh, you're 70. You know, there might be other comorbid factors. They might say, geez, you know, you've been getting a lot of infections and things. This might not be the right drug for you to be on at that point. But it's that there's no good data to drive that right now. We hope to answer that.
Well, thank you to all of our panelists for answering those questions. And thank you to all for these great questions. It helped us realize there's still a lot of work to be done. But I'll invite Dr. Shin back up.
Thank you.